procedures? Mark?
Yes, just real simple. Just if you're not speaking, then please, if you're not speaking, then please mute yourself, because sometimes there's some background noise you're not realizing that's happening, and it interferes with the information. So, you want to speak, just unmute yourself or raise your hand, and we'll take it from there. And that's it. Glenda, I think you're muted.
Yeah. Okay, I'm going to unmute myself and ask everybody to stand up, and I'm going to lead you in the Pledge of Allegiance.
Hang on a second.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. And now the pledge to the Texas flag. Honor the Texas flag. I pledge allegiance to thee, Texas, one state, under God, one and indivisible.
Yeah.
Okay. Okay, we have some of our guests were here a little early and we've met them, but other people haven't. So can we just do this again? Would everybody unmute themselves for a minute? Barbara, I'm going by who I can see. Would you tell us a little bit, give us your name again?
My name is Barbara Ornelas, and I'm a guest of Miss Woolery. And my diagnosis is I have retinitis pigmentosa, so a very, very small vision field, central vision field. And I'm excited to hear about the new information.
Wonderful. We're happy to have you. Bridget, would you introduce yourself again, please?
Yes, I'm Bridget Beinecke. I was invited by Sam Ruiz. I'm a retired architect. I had amblyopia as a child, and I'm interested in all vision research so that I'm a very visual person. I'm looking forward to hearing the lecture today.
Great, great. Well, we're happy to have you. Jack, would you introduce yourself again, please?
Yes, I'm Dr. Jack Pierce. Although I don't push that doctor too hard. I'm a retired retina specialist. I trained, did my fellowship at Shea Eye Institute at University of Pennsylvania. I'm an Amarillo, Texas boy, but I'm now chair of the interspecialty committee of the TMA, and I've been working in local things as well, including the medical school and indigent care, et cetera. And Sam and Tommy and I have been involved with several things.
Well, great to have you. Mary Stubert.
Lions Club.
Hi, I'm Mary Stubert. My husband, Ken, had a retinal bleed and his eye is blind in the center. He was treated with a LASIK thing in Boston by Dr. Reichel, laser, and it didn't work. This is myself. I had surgery for a lens replacement for cataracts, and I've lost my sight in my right eye due to infection. And I'm a guest of Mark. Thank you.
Happy to have you. Patty Woolery.
Yes, I'm Patty Woolery Price. And I read the article in the paper about the presentation. And Barbara Ornelas is a friend of mine. And I knew about her hereditary condition and let her know. And I talked to Mark, who sent me the Zoom link invitation.
We're so glad to have you here. I know we're all going to learn a lot today. Looks like we have one other person. Oh, there's Ken Crone. I haven't seen you in a while. Hi, Ken. There's somebody else that I can't see now. Is there?
Gloria? Did you see Gloria?
Yeah, I've seen Gloria. Yes. Ninel or Nigel or?
She's our speaker today.
Oh, okay. She's not on the screen right now. Okay. All right. Okay.
Is
Well, then-
Gloria a guest?
Yeah, my name is Gloria Lugo, and Trustee Zapata invited me to this meeting because I have a son with cornea issues, and I would like to learn more about it, how I can help him. And I'm a community person, and then I would like to have the information. If anybody in my community, have or this kind of in this kind of situation, I'll be able to at least give the information and guide the people for the right.
well,
the right-
wonderful. We're so happy to have you here.
Thank you.
Do we have any other guests? Well, we have 2 birthdays this week. Chuck Mandelbaum, his birthday is 8/8. Hi, Chuck. Happy birthday. And Ann Rogers is 8/9. Okay, we're gonna have a couple of short reports before we start our program. Steve?
Steve.
Yeah, I don't know if you guys did it last week because I was out, but my birthday was yesterday, 8/4. So
Happy late birthday.
no, I know, which means if we haven't acknowledged it, it means I haven't had it. So I'm actually a year younger. That technically is how it works. So let's do this next year. I'll be 21 in about 8 years.
Why?
Big
Well-
surprise for you, Steve.
Hey, Glenda, I'm checking in. Can you hear me?
Yes, Sam, we're happy to see you here. It's always good when the program and the
Okay.
person who's helping it shows up. It makes you feel a lot more comfortable. Yes. Okay, I have a couple of brief announcements to make. Jim Roberson, would you update us on the sporting clay, please?
Yes, Ann Ward managed to get Joe McBride of McBride's Guns to donate our shotgun this year that he's usually been selling us at cost. So she got him to donate it free of charge. So good for Ann. She did a very, very good job. We have 4 silver sponsors right now and 5 teams. And the only other thing I think she wanted to say, I am working on the ammunition. The guy and my ammunition guy has been out of the country, but hopefully we'll know for sure how much we're going to get for the ammunition. I think, oh, and the flyer. Did everybody check the flyer out that Ann had done and printed? The flyer sporting clay shootout. It's on the, I believe it's on the website.
Okay.
So hopefully everybody got a chance to see that, but that's kind of an update. It seems like we are moving. We need more sponsors. We need whole sponsors. We need teams. And of course, mark your calendars to volunteer and work on the event itself. I think that's it. Thank you.
Thank you. Okay, yeah, he's talking about September the 17th for our sporting clay fundraiser, which we're
Yes.
working on. Okay. Well, speaking of Ann Ward, she couldn't be here today because she's at the Harry Wickersham golf tournament. And she asked us to look at a website. They're having a silent auction. This is a fundraiser for them too. They're having a silent auction. And I looked at the silent auction and they've got a lot of really nice things to bid on at, I think, a very reasonable price. A lot of 2-day, two nights at a nice hotel in Fredericksburg and San Antonio and that type of thing. So I'm going to give you.
And just to remind folks, the Harry Wickersham Golf Tournament is in sponsorship of the Texas Lions Camp. So
Yes.
all the proceeds from the auction and the golf tournament go to the camp.
Correct. Okay. If I can put on a chat on the chat, I will put it on the I'll do that in a minute. I will put on the
Hey, Glenda,
yes.
Hey, Glenda, we have a guest here that I see that she's here. And can I introduce the guest real quickly? I see her.
Certainly.
We already did,
Yes.
Sam.
Oh, Bridget Beneke?
Yeah, I've already been introduced. Yeah.
Oh, okay. All right, Bridget. I just want to make sure. Sorry about that, guys.
You have to
Like y'all to
wake
meet
up
Sam
before noon,
Ruiz.
Sam.
Let's introduce Sam.
That's true. I'm a little slow. Sorry about that, guys.
Well, it's better to be introduced a couple times than not at all. So we're happy. Okay, so I'm going to go onto the chat and put the website for that silent auction. And I think it's worthwhile for you to look, because I say they've got a lot of nice gifts. Mem, would you update us on the new member orientation, please?
Well, we have scheduled the new member orientation for the 14th of August. We have 7 new member respondees, and then we have about 4 speakers. So we'll be working on that, and hopefully every one of those new member can attend. We'll be doing it by Zoom again, and we look forward to that event. Thank you. Thank you.
One more thing, we had a wonderful meeting at a wonderful get together at the Moon Tower Saloon last week. And it was great to get to know everybody a little bit better. We're going to actually have a report on that in a couple of weeks. Lotta is going to talk about that. So if there's not any more announcements, I think we're ready for the program. And Sam, that would be you. And Sam, you're muted.
Yes, I was wondering if Dr. Ninel Gregori, is she online?
Hello, yes, here I am. Can you hear me? And
Oh, yes, we can hear you.
okay, I'm not sure.
All
Hold on,
right,
let me
let
open
me
my
get-
camera so you can see me as well. There I am. Hello,
Hey.
everybody.
Good
Hey, Doc,
afternoon.
I'm about to introduce you, and I thank you for being here.
Hello.
Our distinguished guest. Oops.
Uh-oh.
I'm going to take my video off. Our distinguished guest is Dr. Ninel Gregori, and her topic is gene therapy for inherited retinal diseases. She's board certified, and she speaks 4 languages: English, Italian, Russian, Swedish. You know, when you go from Italian to Russian, that's a pretty good jump. I bet there's a story in that. But anyway, 4 languages. And she completed her residency program training and vitro retinal fellowship at the Baskin Palmer Eye Institute in 2007. Her roles there are: Dr. Gregori is a professor of clinical ophthalmology and vitro retinal specialist at the prestigious Bascom Palmer Eye Institute of the University of Miami Health System in Miami, Florida, and as well as the chief of ophthalmology at the Miami VA Medical Center. Her specialties: Dr. Gregori serves as a surgeon on pivotal clinical trials taking place at the Bascom Palmer Eye Institute, such as gene therapy for inherited retinal degeneration and retinal prosthesis for severe atrophic age-related macular degeneration. Vargas 2 implants, that's a camera that goes back there, it's very, very expensive. Vargas 2 implantation for profoundly blind patients with retinitis pigmentosa, and she also does embryonic stem cell implantations for patients with age-related macular degeneration and Stargardt disease. Research interest. Her primary interests are in the area of innovative surgical techniques and new therapies for patients with blinding retinal conditions without currently available treatment. Her awards: she contributes annually to the American Academy of Ophthalmology and the American Society of Retinal Specialists. Her awards are at the American Academy Achievement Awards in 2017, and for the American Society of Retinal Specialists Award I guess both in 2017. She also was awarded the Michael Redmond MD Outstanding Youth Ophthalmologist in 2013. And Baskin Palmer Eye Institute awarded her Professor of the Year in 2009. And now I complete this on a lighter note. 2 things. 1, today our medical vocabulary will increase. 2, as far as entertainment is concerned, one of her favorites is Mamma Mia. And now I present Dr. Ninel Gregori.
Hello, everybody. I hope you all can hear me fine. Hello, hello. You can see I'm in my office, so you can see some of the cleaning materials and PPE that we use. And that's been a funny and challenging year. Funny in a way that we've really pushed our comfort zone with patient care and with Zoom technology. And I'm able to attend your meeting from Miami, which is we couldn't do just a year and a half ago. So it's been a blessing and it's been a challenge. And I could tell you that I'm so happy to see all of your faces, and I see that you're staying safe. I hope your community is not suffering too harshly from the COVID-19 pandemic. Here in Florida, we've been certainly challenged and our numbers are going up daily. I think we're just as bad as we've ever been, or January, I think, was actually slightly better than it is now. So we are really experiencing a huge spike in cases here in Florida. So I'm honored to be here. I prepared a lecture. I hope that you will find it enjoyable. I'm going to tell you that I've focused on inherited retinal diseases because that's really the area of my research and gene therapy efforts, clinical trials to try to develop therapies for patients with the conditions that we've never really had treatments for. So as Sam mentioned, I'm involved in various clinical trials, and I'm really humbled to be part of them. So go ahead, Mark, you could play my lecture. You can think of any questions that you would like to ask me, and I will try to answer them to the best of my abilities after the lecture. Thank you for having me and for everything that you do for the community and all your humanitarian efforts as part of the Lions Club. Thank you. It's my honor and pleasure to present this lecture on innovative treatments, gene therapy for inherited retinal diseases, to the Austin Founder Lions Club, the oldest continuously operating Lions Club in the world. My relevant financial disclosures are listed here. I receive research grant support from Biogen and AGTC, two companies that sponsor gene therapy trials I will be mentioning. I realize that there are many non-medical people in the audience, so before I go into gene therapy and inherited retinal diseases, I would like to give a little overview to what the DNA, chromosomes, and genes are and what they do. As you all know, all organisms, live organisms, are made up of cells. Inside the cell, there is a round structure called the nucleus. Inside the nucleus, here shown in green, there are chromosomes, or the DNA, essentially coiled together into this funny structure that looks like an X. The chromosomes are made out of DNA, and a segment of DNA is a gene. So it's just a segment of this long DNA molecule that is a gene. Humans have 46 chromosomes that are arranged in 23 pairs. In each pair, one chromosome comes from the mother and the other chromosome comes from the father. Humans have these chromosomes that are numbered 1 through 22. They're called autosomes. And then the 23rd pair of chromosomes is the sex chromosome. So if you have two X chromosomes, you're a female. If you have an X and a Y chromosome, you're a male. There are genes located on the numbered chromosomes and also on the X and the Y chromosome that make the basis for various genetic disorders. If you hear...
Excuse me, I'm going to pause this for a second because we're having some audio problem. Let me see if I can fix that for us. Hang on a second. Well, it says it's sharing the sound.
Mark, it's her sound that's very light.
Okay.
We hear you very well.
Can you increase the volume from your place?
According to this, it should be, well, we'll just try it again, and I'll turn up, I'll tell you what, I think I can turn up the volume on this here, maybe. Oh, that's all the way up.
Dr. Gregori shows us muted on the screen.
But that's okay. All right, let's try it again.
Here, autosomal dominant disease or disorder, that's when the human has to have only one gene, either from the father or the mother, that has the mutation that causes that particular disease. Autosomal recessive means that you have to have two two genes, one from the mother and one from the father, that if you have both, then you have the disease. And there's a term X-linked disease, and that means that the gene for that particular disease is located on the X chromosome, and you just need to have one of those because you have one X chromosome, for example, if you're a male, or if you're a female, you just have one gene, and that particular gene causes the disease. So it's a bit complex, but for the purpose of this discussion, that's all you really need to know about our genes and chromosomes. It turns out that we all carry mutations. There's no such thing as a normal DNA. We are all different. We're different from our mother, we're different from our father, and from our brothers and sisters, from our children. The DNA has very many variants, and some mutations or variants are harmless. They cause no consequences to our health, whereas others cause diseases. And it turns out that our DNA, that coiled DNA in our chromosomes, is exposed to all kinds of factors such as sunlight and food and toxins. And there's also random errors that occur in DNA copying as cells divide in our body. So some of them are harmful and some of them are harmless, but we could all try to minimize the negative influences by protecting ourselves from sunlight and toxins and eating healthy foods. But there are some things that we cannot control. There are some things that come from our mom and dad, or just random errors that occur as we go about our daily life. So here is where diseases occur, and the physicians and the scientists are trying to find ways to cure these diseases by correcting the DNA or correcting the errors that occur in our cells based on these mutations. So how do genes affect us? Here's the process of how it occurs in our bodies. Each gene or DNA is copied into something that's called an mRNA, or a messenger RNA. And then from that RNA, a protein is made. And that protein then determines some kind of characteristic in our body. For example, what color your eyes are, or what color your hair is, or what your nose looks like, and so forth. Of course, there are multiple genes that determine all these characteristics, but nevertheless, each gene then is translated into a protein that makes some type of a function within our cells. So how could harmful mutations affect our health? Well, here's a picture that shows that from a normal gene, a normal protein with a normal function is translated. A mutated gene causes either abnormal protein production or no protein at all. And so where a normal process would require a normal protein within our cells, all of a sudden there is a complete stop or abnormal function that occurs, and our cells do not work well, and our body as a result do not function well. So that is how mutations can harm sight and other functions within our body. And now, before we go into genetic diseases of the eye, just a quick anatomy of the human eye. Here in cross section is an eyeball. You can see the front of the eye is called the cornea, and that's where the light comes in. Then you have the colored portion of the eye called the iris, and then the light travels through a lens and onto the inside of the eye through what's called the vitreous body and into the back of the eye, which is called the retina. So you have a lens, which can become a cataract. You have the retina, which is the film or chip of the eye camera. And also the other common condition that people talk about is glaucoma, and that's when eye pressure is too high in the eye. So I just wanted to show you that that happens where the fluid from the eye does not drain well. And so these are common terms that one hears: a cataract, glaucoma, and then retinal disease. And that's the basic anatomy. So we will be referring mentally to these pictures as I go through the rest of my slides. Since we'll be talking about retinal inherited diseases, I would like to orient you a bit to the structure of the retina. So the retina is this yellow, thin structure that lines the inside of the eye, right, shown here on the left. The retina consists of many various cells that essentially take up light, convert it into an electric impulse, process it, and then send it off through what's called optic nerve to the brain. And there are various cells, and the ones that we hear the most about are the rods and cones. Now, the rods and cones are the photoreceptor cells. These are cells that actually take up the light that comes into the eye and convert it into an electric impulse. And the cones are responsible for your central vision. Whenever you look at anything directly, you're using your central vision. You also see colors with the cone cells, whereas the rods are responsible for the night and your side vision. So when the lights are dimmed, it's the rod cells that make you see. And also when you look straight ahead and you can see to the side, which is your peripheral vision, that's also the rod cells. And there are many conditions in the eye that result in atrophy or disappearance or death of these photoreceptor cells. And so the vision will deteriorate either at night or during the day, or sometimes in both conditions. Here's an example of the normal retina. You see the yellow optic nerve, that's what it looks like. This is what ophthalmologists or eye doctors see when they look inside your eyes. So the yellow circle is the optic nerve, through which then the electric pulse travels to the brain. The red lines are the blood vessels, veins, and arteries that supply the retina, the orange tissue. So that orange tissue is the retina, and that's where all those rods and cones live. That's where the vision is generated. So now that we've seen what the normal healthy retina looks like, I'm showing examples of some retinal diseases. The upper left image shows a patient with choroideremia. You can see that yellow color throughout the retina where the nice orange color has been lost. These patients lose night vision, peripheral vision, and eventually central vision. And there are no current treatment available for these patients. The upper middle image is a patient with dry macular degeneration, and the upper right is wet macular degeneration with a large hemorrhage. The patients with wet macular degeneration have to undergo monthly injections of medicines into the eye, and there's hope that gene therapy one day will replace these frequent unpleasant treatments and provide a more reasonable therapy for these patients. The bottom left picture is a patient with achromatopsia. These patients' retina looks pretty normal, pretty orange. However, they have abnormality in their cone cells, so they do not see colors, and they have low visual acuity. Their eyes shake, something that's called nystagmus, because the babies are born with poor vision and never develop that steady eyesight. The bottom right is a patient with retinitis pigmentosa, a common inherited disease. You can see black spots of pigment all over the retina. It does not look normal. And again, this is a condition that's rather common, and we do not have treatment to prevent visual loss in these patients. So this is where researchers are working hard to try to come up with treatments for these patients without therapies so far. So let me now introduce you to gene therapy and explain to you how it works. Here you see a DNA that's encoding normal gene. So in some of these patients that I just showed you, the gene is mutated, the protein is either absent or is abnormal. So they're missing that normal protein inside the cell, and therefore the cell cannot function. So the idea is to take up a made in the lab DNA that delivers a normal gene, package it into a virus that now carries that normal gene, inject it into the human body, in our case that would be the eye, and that virus does what it does. It gets into our human cells, and then it releases that normal gene into our cell. And then all of a sudden, our cell is able to produce normal protein from that normal gene that the virus kindly brought to it. So all of a sudden now, our cells are producing the normal gene, and the function hopefully is restored so that the cell becomes or functions more as a normal cell. So that is how gene therapy works. And into the eye, gene therapy can be delivered by a couple of different ways. The first is just an injection into the inside of the eye, very similar to those injections that patients with diabetic retinopathy or macular degeneration receive in their routine clinical care in ophthalmology offices. Or it could be an injection of virus under the retina, which actually requires a trip to the operating room and a very precise and skilled operation. There are a couple of viruses that are used. They're listed here, AAV virus or lentivirus. Anyhow, these are harmless viruses to our bodies. They do not replicate or they do not divide in our bodies. They just deliver the gene, get into our cells, deliver the gene, and that's it. And then they are degraded. So you do not produce the virus in your body. You just receive the gift of the normal gene into your cells that is delivered by these viruses. And this is a schematic of how this subretinal injection would work. Essentially, a retina specialist performs surgery, gets to the retina, and then very skillfully delivers this virus onto the retina, watching the retina through specific Good afternoon. It is my honor and genes affect us or abnormal function that my slides about are the in the eye and that's where all those rods and cones live. That's where the vision is generated. So now that we've seen what the normal healthy retina looks like, I'm showing examples of some retinal diseases. The upper left image replicate or they do not divide in our bodies. They just deliver the gene, get into our cells, deliver the gene, and that's it. And then they are degraded. So you do not produce the virus in your body. You just receive the gift of the normal gene into your cells that is delivered by these viruses. And this is a schematic of how this subretinal injection would work. Essentially, a retina specialist performs surgery, gets to the retina, and then very skillfully delivers this virus onto the retina, watching the retina through specific
Dr. Gregori, it looks like that was a 15-minute presentation. Is your presentation actually supposed to be longer than that?
Yep, it is. It should be. So
let me see if I can play the one that you tried to send me earlier. Oh, no, I think that one's gone now.
But if you downloaded the video, Mark, it should, the entire file should be there, I'm hoping.
Yeah, the original one that you sent me earlier was in Dropbox. So if it's not in Dropbox anymore, I don't have access to it.
Would you like me to share it with you again?
Yes.
I just sent you, Mark, the link again.
Okay, I'm waiting for it to show up here.
Mhm.
Good afternoon. It is my pleasure to present this lecture on innovative treatments, gene therapy for inherited.
So my file goes through 33 minutes.
Okay, well, all I'm getting is the first 15 minutes of it.
The link I just sent you,
Uh-huh.
that's the one I'm opening, and it's 33 minutes. Can you try to open that one?
That's what I'm looking at.
Good afternoon. It is my honor and pleasure
And
to present.
it only shows 15 minutes. Your Dropbox. Okay, hang on a second here. I think I found a way to do it. Hang on a second.
Good afternoon. It is my honor.
Okay. Let's see where we were. Right about here.
Hey, Mark, Sam, I was able to somehow opened it and I got the whole 30-something minutes. And I have it down here as a file
Sam.
called Windows Media.
Sam, I've got it. I've got it, Sam.
Oh, you got it? Okay.
Into your cells that is delivered by these viruses. And this is a schematic of how this subretinal injection would work. Essentially, a retina specialist performs surgery, gets to the retina, and then very skillfully delivers this virus onto the retina, watching the retina through specific imaging technology that's incorporated into our microscopes. And this is the mechanism for many of the currently developed and developing gene therapies that are in clinical trials. This is how the surgeons deliver this form of therapy. Going forward, probably viruses will be designed in such a way that one does not need to do this complicated surgery, but just do an injection into the eye, and then the virus kind of moves through the retina and delivers its contents to the cells of, the photoreceptor cells that are cones and rods. And it will be perhaps a much simpler a procedure to undergo without a trip to the operating room. And here are various types of gene therapy that are being developed for the eye. The physicians, ophthalmologists in the audience will, this is for you, and you could see the various methods by which gene therapy perhaps will be delivered to the eye. You could replace an abnormal protein that's appropriate for autosomal recessive diseases, and that's the most common form. One could also add additional growth factors to help the cell function better. Neuromodulation is a newer therapy that's received attention in the news just within the past month. It's optogenetics, and I'll talk about that a little bit. You could also do suppression, where the gene that creates the disease needs to be suppressed. So that's mainly for autosomal dominant diseases where that abnormal gene needs to be silenced. And then also gene editing, direct gene editing in our cells by a method called CRISPR. And that's actually modifies our own DNA to try to correct the mutation that's causing the disease. So there's various ways, and I'll talk to you a bit more about some of these in the next slides. Now, I decided to include this slide about optogenetics because this particular newer form of therapy just received great attention in the news. And essentially what it does, it makes cells that are normally unable to directly respond to light sensitive to light. In the eye, these are ganglion cells. The ganglion cells, and again, this is for ophthalmologists in the audience perhaps, these are cells that that essentially need photoreceptors, those degenerated cones and rods, in order to receive the electric impulse. And in patients who've lost rods and cones, the ganglion cells are silent. They're not able to respond to light because they are not designed to be light sensitive. So what optogenetics does, this is kind of science fiction, but it takes this algae, this green little organism, one cell, and this little organism has light sensitive proteins in it. So that's what make it glow. So the scientists have taken a gene for these particular light sensitive proteins, packaged it, and delivered it via a virus injection into the eye to the ganglion cells. And so now the ganglion cells, which are normally not light sensitive, become light sensitive. So they're able to respond to light. They're able to sense the light, just like the rods and cones did before they degenerated. And to help the ganglion cells perceive this light, a special set of goggles was developed that I will show you on the next slide. So here we are. We've injected these algae derived, not the algae itself, but these are just the DNA for this particular protein. It is delivered inside the eye via an injection. Then these little proteins are incorporated, or they kind of percolate into the cells, the ganglion cells, and then the light is able to stimulate them. And so in order for the light to stimulate the ganglion cells well, the patient wears goggles, and the goggles have, you know, a sort of a special chip on them, and then they transmit the light into the eye of the patient, stimulating these cells so that the patient is able to perceive light. And right now, this therapy is being developed for patients with retinitis pigmentosa that have completely lost their ability to see or have very low vision left. And so here is the first patient that was just reported recently in the news. It's a patient in France that has retinitis pigmentosa. He's 58 years old, and he could not see any light, or barely light, so he could not pick out any objects or see whether the lights were on or off. He got this injection and he's wearing these goggles, and all of a sudden he's able to pick out high contrast objects. So here's a notebook and also some tumblers he was able to identify against the white background. So very early, but it's a new step in the new direction, the ability to essentially restore some light perception, some ability, some primitive form of vision to patients who lost all vision. And it's only going to go forward. This is the first step. That's something that I wanted to show you and share with you because, again, I think it's an exciting step forward. And the next form of therapy is something that is able to fix our DNA directly. How about not requiring a normal gene delivery into the eye? How about just taking our own DNA and repairing, as this picture shows, just repair the DNA, eliminate the problem mutation, and restore the function to the cell. And this form of therapy is called CRISPR. It's a long fancy name, but it's essentially what it is. It's an enzyme with an RNA molecule that is delivered into our cells, and it finds the mutated portion of the DNA, attaches, cuts out the bad DNA, and repairs it according to the message within this RNA molecule. So again, that's something that's being developed for and being actually tested now in clinical trial for patients with a really severe form of retinitis pigmentosa, or LCA, with a CEP290 mutation for those ophthalmologists in the audience. It turns out that there are so many genes involved in inherited retinal diseases that can cause blinding diseases to the eye. And you could see how many of them, and the same gene can cause even several different diseases. So it's a complex situation. And the goal, of course, is to develop some type of therapy that would be appropriate for patients regardless of what mutations they have, like CRISPR or optogenetics, where you could actually treat patients with various genes instead of having to design a individual therapy with an individual virus for each particular genetic condition, which is so complex. But again, this is the beginning. We are doing the best that we can with the current science that's available to us. And in 50 years, I predict that the way we practice ophthalmology, the way we treat patients, is going to be completely different from what we're doing now. But we're making those initial steps, and it's very exciting to be part of it. So let's now talk about some of these diseases where researchers are actually making progress in designing treatment. The first one that I would like to speak about is called retinitis pigmentosa. It is the most common progressive degenerative disease where patients lose both rods and cones. So they lose night and peripheral vision first, and then eventually the central vision. It's very common. It's seen in about 1 in 4,000 people in the general population in the United States. It's not just one condition, it's a group of different diseases that are caused by over 100 different genes. And even babies can be born with poor vision due to this condition, and it's called at that point LCA, and it's caused by 15 different genes that we know of. And so far, up until just recently, we had no treatments for these patients. Now, the exciting news is that back in 2017, in December of 2017, the FDA approved the first gene therapy for retinitis pigmentosa for patients with the specific mutation, RPE65 mutation, that causes retinitis pigmentosa and related conditions. And it's called Luxturna or voretigene parvovec. And it's delivered by that subretinal injection onto the retina. And it is, for those in the audience who want to know, it's the AAV2 RPE65 vector. So it delivers the RPE65 enzyme or gene that produces the enzyme into RPE cells. after the subretinal injection. And so this is how the procedure is done. It's in the operating room. The surgeon performs what's called vitrectomy, remove the vitreous, which is a gelatin sort of structure that fills the inside of the eye to get to the retina, and then injects the medication onto the retina. Now, it used to be that there were two surgeons involved, where there was an assistant who injected, as you could see in this picture, through the syringe, this medication. Nowadays, those of us who perform it do it with the machine, so it doesn't require necessarily a second surgeon. And there are 10 centers of excellence in the United States that deliver this medication because they have enough resources and skill to perform these operations. The company that makes Luxturna provides patient support. They assist with travel, with coordination of services, and so forth, and also to get approval from the insurance. The cost of therapy is tremendous. It's $850,000 because this therapy is delivered to both eyes. So between the two eyes, that's how much it would cost. And many insurances cover this. Of course, doctors and the patient advocates help get the approvals. And this is how the injection would work. There is a tiny needle that goes through the retina, under the retina, and the medication then is delivered. Video showing the injection of voretigene or Luxturna onto the retina. Again, you could see how the surgeon has to be very steady to deliver this medication safely into the patient's eye onto the retina. And here you see us smiling. Dr. Jana Davis is on the left and I'm on the right. After one of these successful first operations, we treated back in 2018 our first patient who was 17 years old at the time, a young man who presented with this RPE 65 associated retinitis pigmentosa. We treated him, and he had, after recovery, about a month or so later after therapy, in both eyes, he experienced significant improvement in the visual field or the breadth of vision that he had, and also improvement in night vision. He didn't need lights to be able to navigate around his house and so forth. He had also some mild improvement in his central vision. He was also able to get a driver license. Restricted today, like driving, but nevertheless able to drive and be more independent. So for some patients, it really changes their life. Of course, not every patient, especially if they have advanced disease, will benefit. So we've treated 9 patients so far, and the younger ones, or the ones that have less severe disease, benefit more from this therapy. Here you see photographs of his retinas, the right and the left eye. You could see that irregular pigmentation, not a nice orange color that I was showing you previously. Here we outline the area under which we injected the voretigene or Luxturna. You could see we made 2 circular areas injecting this medication in each of his eyes. This slide shows Dr. Barakal, Ardina Barakal, hugging one of her, actually this was her first patient, a 9-year-old boy, and her performing the surgery. She is our pediatric retina specialist, and she treats young children with the RPE 65 diseases. So she's treated 7 children so far, and this child had the surgery back in 2018, And just a couple of days after surgery, he no longer was bumping into things. And within a month, he was no longer using flashlights to see it in dim light. He was able to read paperback books, not just on an iPad, and exploring outdoors more. So his mother is very happy with the changes that he maintained after the surgery now for several years. What else is ongoing at Bascom Palmer Eye Institute? On the slide I've listed the clinical trials that we're involved in. We are performing work in choroideremia, X-linked retinitis pigmentosa, achromatopsia. I've shown you pictures of these conditions, also dry macular degeneration and others. Now, this is a photograph of us at Bascom Palmer with our first patient that we treated with X-linked retinitis pigmentosa. Dr. Davis and myself performed the surgery, and these young men, this is an X-linked condition, so only men get the disease, and the mothers are carriers. So these patients are, when they're young males, experience peripheral and night vision loss, and eventually central visual loss. It's a very common gene that causes this 70% of cases of X-linked retinitis pigmentosa, where the gene is located on the X chromosome. So this is definitely a more common gene. So we're excited that the first U.S. patient was treated a few years ago, and then we treated more patients in this clinical trial. And now some of the results have been positive results, promising results have been released from phase 1/2 trial. So here is the picture of the publication that came out in March of last year, 2020. This is a phase 1/2, so very early, still looking for a safe dose of medication for patients. There were 18 patients enrolled, 18 men, ages 20 to 50 years of age. The virus here is, for those ophthalmologists in the audience, AAV8 that delivers a normal copy of RPGR gene. All patients described subjective improvement in visual clarity and increase in field of vision. So their vision was a bit wider after therapy in the treated eye by 1 month compared to the non-treated eye. This was only one eye was treated. So the visual field widening was documented in 6 patients. Visual acuity was stable at 6 months, so no one lost vision. There was a patient even with increase in the retinal thickness on the OCT, that imaging device that I was showing you, potentially pointing to regeneration of photoreceptors. Again, very early data. We need to see what comes from phase 2 and 3 going forward. In conclusion, gene therapies for various blinding inherited eye conditions are in clinical trials. Genetic testing to find out the exact mutation that causes a patient's disease is essential. It is the time to know what mutation the patient has so that the patient can participate in clinical trials or receive the treatment once it's FDA approved. The first gene therapy has been FDA approved for RPE65 retinal diseases, and the future of patients with inherited eye conditions is bright. It's very humbling to be able to participate in the clinical trials and help patients with these conditions that never had any treatments until recently. And it is a great pleasure to present our work here to you. And thank you for your attention. I'm happy to answer any questions. Thank you for putting up with this long lecture. It was very long, I know, but I wanted to make sure that I explained everything in a fashion that non-medical, non-physicians could understand. So, yes, Sam.
I've got a got a question for you. When we talk of glaucoma, which is very prevalent in Mexican American people, in glaucoma, when the eye pressures increase because of the tear does not drain properly, how does the front action of the glaucoma affect the retina in the back? If the damage is being done up front, how does it get all the way back to the retina and causes people to go blind?
So glaucoma is actually, can you hear me okay? You hear me?
Yes.
Beautiful. Glaucoma actually results from inadequate drainage of fluid from the eye. So the pressure inside the eyeball builds up, and it doesn't even have to build up very high, because in some patients, even normal pressure, what you think of normal pressure, could result in glaucoma. So that's called normal tension or normal pressure glaucoma. So, but the way it causes damage to the retina is by increasing pressure in the eyeball. The eyeball is a closed space like a balloon. So you can imagine that if you add extra air into a balloon, the pressure goes up. Well, if you add extra fluid to the eyeball, the pressure goes up. And when the pressure goes up, it just presses so hard on the cells in the back and the retina, and it causes those cells to die. So we don't understand exactly the precise mechanism by which that happens, but it's the pressure that essentially probably affects the perfusion or how much blood is delivered to the cells of the retina and the optic nerve. Really, that's the main area of damage in glaucoma, is the optic nerve. But there are cells in the retina that make up the optic nerve, so those cells die in the retina as well. And those are the ganglion cells that I was talking to you about for so long. The ganglion cells are the cells that die in glaucoma.
Dr. Gregori, one comment. A person can actually be 20/20 and see okay and have glaucoma thinking that he's okay, because they're two separate completely things. And if you're not checking for glaucoma, you could be thinking you're okay because you're showing 20/20 all right, and you really have a serious problem. So you need to check separately for the glaucoma.
That is correct. Many patients will keep 20/20 central vision, but they will lose peripheral vision or that side vision. And so their vision slowly comes to a tunnel vision. And at that point, they realize that there's something going on, but it's frequently it's too late, because you can't regain that loss of side vision once it's gone. You know, there are some nuances to that, but yes, one has to be checked for glaucoma because it is something that can definitely cause permanent visual loss. Unlike cataracts, cataracts are just the lens of the eye that becomes opaque rather than transparent. And so that could be easily repaired by cataract surgery, where that lens is removed and an artificial lens is placed in the eye to replace the opaque natural lens.
Norman, then Steve, then Tommy. So Norman, go ahead.
Thank you very much, Dr. Gregori. My name is Norman Tyring, and I noticed that you indicated the different kinds of problems of the eye, including principally AMD. Could you tell me a little bit more about central serous? We're very familiar with having to have monthly injections in order to reduce the fluid under under the retina, the skin of the retina, let's call it that way. Correct. And so are there any new technologies also in regard to that particular problem?
So central serous is a condition where fluid leaks onto the retina, and it can also cause new blood vessels to grow, just like what happens in macular degeneration. And it sounds like, because you're getting injections, that's probably what occurred in your eye, where there are new blood vessels that have grown and they leak fluid, and so they cause swelling in the back. And so those injections help to relieve or to remove the swelling or improve the swelling in the back of the eye under the retina or within the retina. So central serous is actually one of the more challenging conditions, I would say, even though it's not inherited in any way. Of course, we don't know. We might find a gene for it that predisposes patients for having it in the future. But so far, we don't know that it's caused by a genetic condition. So there's injections. There are oral medications that help some patients with central serous. Is there work being done? Yes, but there's nothing yet out there that would help you more than the injections. So like I was mentioning, there are some diuretics, actually. It's called spironolactone. It's a medication that can help some patients with central serous, but not everyone. And so it depends on what exactly is going on with your retina too. So talk to your retina specialist. I'm sure that they would consider that if it would be helpful in your eye.
Sorry. So in other words, you're considering this, this turns out to be practically a periodic maintenance therapy that is required in order to ensure that the bulge does not increase. We were hoping that over time that maybe the period between injections would increase.
Right.
And so far we haven't seen any indication that staying helping to go beyond a month and a half.
Well, I could tell you that other medications are being developed for macular degeneration, and sometimes those same medications could be used for your condition, for central serous. So with time, though, it is very common to see that the interval will increase, and it may just take a few more years or months, depending on your eye. And if it increases, great. But if not, there may be some other medications that are developed for macular degeneration that may be helpful in your case as well. So once again, right now there's nothing yet to tell you that's available, but research is moving at such high speed that I would guarantee that in the next several years, you'll have another option.
Thank you very much. I appreciate it.
You're welcome.
Steve?
I actually didn't have a question. Sorry.
Okay. Tommy?
Yes, I do have a question. First of all, I agree with Sam. If there were a test after this on vocabulary alone, I'm quite certain I would fail. I'm sure you're aware that our Lions Club is currently involved in screening for children in AISD and 2 other school districts, as well as community screening. About 1,800 folks last time we were in the screening business. I understand what we use is a well-challenged spot camera. It's a 1000, and it tests multiple pieces of your eye, but it does not do glaucoma. It's my understanding that there is an instrument that is in the industry right now that may be financially accessible to us that would in fact test glaucoma. Are you aware of that instrument? And if so, cost, location, how might I acquire that to make glaucoma part of our testing or screening before we allow the kids to go on to their testing? Do you have any comments about that?
Thank you, Tommy, for your comment. So let me just understand. So you would like to check probably pressure inside the eye. So that's how you would test for glaucoma in these children. That's what you're referring to, I imagine.
Correct.
Yes, and there are multiple devices that check pressure. I could certainly email Sam a few names of the devices that you may want to acquire. They're not very expensive.
Are they invasive? Are they invasive in any way? Because we really run a risk, as you might imagine, dealing with children, that parents are concerned that we're creating a problem, not solving one, and they're very cautious about that. So is this, or do you think these are invasive sort of, where we have to touch the child's face and eyes and ears and nose to be able to hold them still to do something? Or are these something that simply by camera appearance we can resolve?
Right. So you cannot really test pressure with well, I shouldn't say that, but but the main really way of testing for glaucoma is checking the pressure. And there is a device that is non-contact. In other words, it does not touch the eye.
Perfect.
So
perfect.
I'll send you that name.
You can send it to Sam. He and I are both going to be interested in acquiring this and sharing it as we do we have 2 of the well-challenged cameras we use right now. Thank you so much for your presentation. I'm trying to digest everything you gave us. It's like drinking from a fire hydrant. Thank you.
I understand, that's why we go to school for so long, because it's a lot of information that we have to remember.
I appreciate it. Thank you.
Thank you. Anyone else? Yes, I see a hand.
Gloria, we can't hear you.
My question is a little silly, a little ridiculous, but I'm just curious. Do animals have these problems? Or is it?
Well, actually, animals do have eye problems, and they develop cataracts. They develop, I imagine they develop glaucoma, why not? But they certainly develop conditions, there are some inbred dog breeds that develop even a condition that's similar to retinitis pigmentosa. In fact, that's where research is done first on animals to any treatment anything you take as a medication. So you could think of all your pills that you have taken over the years and any new treatment that you will ever take, that all of those are first tested on animals. So bless their hearts, and they help us. Certainly the animals are treated with respect and kindness, and there are standards for treatment of animals that are used for research, but yes, they do. And in fact, I had a fish, you guys won't believe me, but I had a fish, a little African cichlid. It lived 15 years in my fish tank. My mother is so meticulous at maintaining the water. Okay, so this fish was with us 15 years because we got her, this fish, a year before my son was born. And now my son, the second son, is 14 years old. So the fish passed away just this year. So, and it lived a year longer than him. That's how I know how many years it has been with us or was with us. So 15 years, and it developed a really whopping cataract that I could see across the room. So they do, even the little cichlids develop cataracts. It's amazing.
Thank you.
Barbara has her hand up. Glenda, I think this will be our last question.
Yes, so I have all three of those conditions that you named. I have cataracts, I have glaucoma, as well as RP. My right eye is a whole lot worse than my left eye. And pretty much I've probably been to 40 specialists. And when we get to the RP part, it's just like, you see that, like, it's like a death sentence. So are there any doctors in this area that specialize in these kind of treatments or providing kind of assistance? And if so, are those these type of specialists don't seem to be covered by my insurance? So is there any kind of program or any kind of assistance or anything that helps with any of this kind of treatment?
So I would say that the first thing, Barbara, is you need to have genetic testing so that you know which mutation you have for the retinitis pigmentosa. And there is free testing that you can obtain through Foundation Fighting Blindness, through one of the physicians that can just, it's an easy thing to collect your DNA. All you take is a little brush and you just brush it against the inside of your mouth, put it in a little tube and send through the physician that participates in this to the Foundation Fighting Blindness. And then you can get genetic tests done and genetic counseling. So they could talk to you because you're a young lady, and for your children, you would need to know what is your risk. Can you pass it on? What does it mean for your children, for your grandchildren, and so forth? So certainly that is important. And I would say that a large academic center in your area is where I would go, or I would reach out to them, because they would know which provider within their network, academic center, or they will collaborate with frequently with people in large research-oriented private practices in the area that would be able to point you to the correct person to go to. And what I'll do is I will reach out to Foundation Finding Blindness and find out for you if you'd like. You just need to send me where exactly you live in Texas. So I'll find out, you know, who would be the closest person that works with them. And you could go, or you could reach out to them and you know, have yourself tested.
And one other question. It seems like it is more visible in our on my female side of the family, my grandmother, my mother, myself, and one of my daughters, her doctor has told her that she probably has the beginning stages of it. When we're sending my grandkids or my children to the doctors, what is it that we need to tell them? Because us just saying, you know, mom has RP doesn't seem to be enough for them to, I guess, require those tests. So is there anything specific that we should be telling them?
So I could tell you that genetic testing and gene therapy is such a new field that unless you see someone who is interested and who is involved in this research, they won't know. And all you ever learn about RP is that there's no treatment, right? So you really need to go to someone who is really into this particular area of retina practice. So again, and knowing your mutation, knowing exactly what is causing your particular condition will open up all kinds of doors for you, because there may be a clinical trial going on already and you might want to enroll. And, you know, many of these clinical trials enroll children also. So, you know, the Luxturna I was telling you about, they enroll patients over 3 years of age. So they treated patients between 4 and 44 years old and so forth. And so maybe you and your daughter could be participating, and there's so many of them. There are natural history trials, for example. You know, doctors are still learning, what does this mutation do, for example? You know, we don't know how without treatment patients progress. And then there's also treatment that's being designed. So it's always good to be plugged into someone's practice who really is into this particular area of retina. And if you ever want to go to Iowa, is a little far for you, but there is a Carver lab at the University of Iowa that essentially provides free care. It's charity-based care to patients, and they also do genetic testing. But it may be easier and closer to home just to go through Foundation Finding Blindness. So I will find out if you just through Sam, send me exactly where you live, so I could ask them, you know, for a provider nearby. And all the best to you, Barbara.
Yes, thank
Barbara.
you so much. Yes, sir.
Barbara, this is Jack Pierce. You know, we have at the new med school, the Wong Eye Institute. And that's who you should reach out to in Austin to begin with. And I think Jane, who's, oh God, I'm blanking on her last name. The chairman will be able to help you with that. And probably the closest that you get would be either San Antonio or Houston, I would guess. But that's a good connection for you to have anyway, because they're right downtown here in Austin. So reach out to them.
Could you say that name one more time?
Has a great retina and eye clinic in San Antonio. Sure.
Could you repeat that? I'm sorry.
Wong Eye Institute, W-O-N-G. Mitchell and Shannon Wong.
Now, if Houston is not too far for you, then they certainly are involved in they deliver Luxturna, so they're one of the centers of excellence. And there is Christina Wang, W-E-N-G. Our fellow here at Bascom Palmer. So we trained Christina. She's now in Houston at Baylor. And at Baylor, they're involved in clinical trials, and also they administer Luxturna. They're one of the centers of excellence. So provide genetic testing. Christina Weng, W-E-N-G.
Yeah, Jack, this is Rudy. I think the name you were trying to remember was Dr. Jane Edmond.
Edmond, right, exactly right. And Jane has connection to Baylor. She was a resident there, and the administrator also at the Wong Eye Institute has those connections as well, and his name is Randy Shepard. They're the first ones to go through. They'll know how to get you there, and you know, anybody else locally is going to look at RP and say basically, hey, there's nothing I can do, you know. So I think that's the best way to reach out.
Hey, Dr. Gregori, Dr. Jane Edmond, who is the chair of that Mitchell Wong Eye Institute at the university, she's a member of our Lions Club. And so we can probably reach out to her in that regard too, since this person is on the screen, we can reach her. So Dr. Jane can do that. And by the way, that's Dr. Jack Pierce, ophthalmologist, retina and vitreous surgeon, and he is tremendously supportive of our program. He helps us out whenever we can. So I didn't know that Jack was on there, but good to see you, Jack.
Great. Nice meeting you all.
Well, thank you so much. This has been wonderful. I know that we could talk with you all afternoon. It's been fascinating. It's just been fascinating. Let me tell you about the program for next week, and then we will close. Next week, the speaker is going to be Milton Dare, and he's the Director of Development and Major Gifts at the Texas Lions Camp. And he's going to tell us about how to raise money successfully. His program is called Fundraising 101. And since we're working on 2 fundraisers right now, I think it will be very, very beneficial.
Well, thank you so much for having me. Thank you for all the beautiful work that you do to help screen children and all the other charity functions that you run as the club and as the organization as a whole. Thank you so much. Stay well, get vaccinated, be careful, and perhaps we see each other again in the future. It's my pleasure to present to all of you. Thank you.
Thank you. Quick, before we leave, I have one question.
Yes.
Well, I'm sorry. This is I'm trying to send out a chat, and I wrote down here to everyone. How do I get the chat out? This is about something else.
You just click on the chat button at the bottom, and
I did, but
okay, did it go to everybody?
It said it did, but I don't see it up there. Do you see a chat from me?
No.
What?
No. When you type it in, just hit return and it should go.
Well, I pushed in everybody, send chat to everyone, and it didn't. Oh, well.
Push return.
Push return?
At least we can go to the moon.
It's the little things that just drive you crazy. Send chat to, and I said everyone, and nothing happened. So I'm sorry. But we could play with this all day, but I think we need to move on.